All right, hey everybody. Sorry, can you hear me okay? I'm not Mike, so I kind of yelled just then, and I apologize. So, welcome to our talk on designing a palliative care curriculum for your residency. Everyone in this panel is dual trained in EM and palliative care and work within the educational sphere within our academic institutions. We have no disclosures with regards to any of this. The objectives for this are evident on the slides that you can download, so we're going to just kind of get right to the point and talk about the subject at hand. So what does the state of palliative care education look like in emergency medicine? Over the last 10 to 20 years, this has grown a lot. There's been a number of different needs assessments among residents, among program directors, and essentially everybody agrees that palliative care skills are important for EM practice, and folks report that they're not adequately trained on how to provide palliative care in the emergency room. Some specific areas of need include managing hospice patients, withdrawal of life-sustaining treatments, prognostication, and symptom management. The extension of that is folks have started to build different curricula, and we cite one here, which is the EPIC EM curriculum, which was adapted for residency and can be done asynchronously. But probably the most important thing for anyone in this room thinking about designing a curriculum for their residency is the bottom left-hand paper that was really the development of educational domains for EM palliative care in the milestones framework for the ACA-GME. This is sort of like a must-read paper, so I highly recommend you look at that. Essentially breaking down the skills into 3 categories. Basically, primary palliative care skills, so providing palliative care as an EM physician, identifying palliative care, hospice and palliative care needs, but then also sort of the logistics and transitions around hospice and palliative care. And then they sort of map those onto milestones. So please use those milestones if you're thinking about developing your curriculum. But from there, we want to talk about the ways to actually build out a curriculum and the ways that this material can actually be taught. So lots of different modalities can be used, but what modalities can you use to teach palliative care? Rita?
So you can figure this out yourselves, but traditionally, what do? We do the tried and true lecture, right? Okay, that gets us the didactics. We'll go along with that. You could also do small group discussions. Okay. Interactive chalk talks with multiple colors of chalk. You could use that. That would be great. Another thing that our residents do, and I'm sure they do in your facility, is asynchronous learning. And that can be, they might have to read articles, they might have to do modules, they might have to listen to podcasts. I'd like to tell you about sort of a new modality that some of you may have already tried, and that is to use ChatGPT as the patient or the family member. I see heads nodding in the audience, so I see that already. So people are given prompts, and then the learner goes ahead and has a serious illness discussion with the computer and then gets evaluated on how that went afterward. And that's a good thing to do before you give the training that you're doing, okay? So those are all things that we're probably all doing now, but what I'd like to really focus on is innovative methods are really the gold standards, and that would be doing things like group coaching with skills practice and simulation. That's really where you're going to get the biggest bang for your buck. And one of the things that we've implemented is something called Vital Talk, and that's where you will move through a very structured way to teach your learners. And we'll talk more about that later. And then simulation, and you can look it up at vitaltalk.org if you haven't heard of it before. And then obviously simulation in the sim room. That can be really good if you're using an alive person. If you're using someone who might be a mannequin, then it's a little less easy.
Perfect. And Dan Miller actually heads up their sim program. So what does a palliative care simulation look like?
So a palliative care simulation is going to be dependent upon what milestones you're trying to hit. So what I've shown here are some of the milestones from the paper that Daniel mentioned earlier, and then I've mapped them onto simulation-based objectives. So this is a simulation where we're going to probably want to use a mannequin or a high fidelity simulation. And that's because what I'm teaching here, I can translate to objectives that you use a mannequin for. So I have a patient who presents and they're in respiratory distress. They have advanced directives already, and you can use the mannequin to demonstrate respiratory distress. But what we're trying to teach the resident is how to know to ask about advanced directives, how to interpret an advanced directive form, how to use that to select appropriate interventions and avoid selecting inappropriate interventions. And then the response of the mannequin can help them figure out how to dose appropriate medications. So those are some milestones. I'm going to want to use a high fidelity mannequin to teach palliative care skills. On the other hand, there's another set of milestones that I probably am not going to want to use a mannequin or a high fidelity simulation. I'm going to want to, these are going to be things that are more like responding to emotions and those real interpersonal milestones. In that case, I'm going to want to use a trained actor, because mannequins can do a lot, but they're not very good at demonstrating emotion. You need trained, standardized patients who can demonstrate this emotion. So I don't even need the patient necessarily in the room. I have I'm imagining a simulation where a patient experiences a devastating injury or a devastating event prior to arrival. They have circulation, but they have clinical signs of brain death. I just present the learner with that information to start the simulation. Then I get to test prognostication by having them recognize organ failure and make a prognosis. I get to allow them to practice delivering serious news by interacting with that standardized patient. Maybe you have two standardized patients and they're in conflict with each other about what they want to do. So then they get to address that milestone of conflict resolution, and they're going to have strong emotions. So they'll be able to use an evidence-based approach to responding to strong emotions, such as a nurse mnemonic. And by selecting the milestones that you want to address and then designing your objectives to address those milestones, that's how you're going to figure out what your simulation should look like.
And it's all well and good that we can talk about what content needs to be taught and how to teach it. But as we all know, educational time is tight in the residency curriculum. So how do you get buy-in for palliative care education within your residency? Any thoughts, Justin?
So one of the things that's really helpful by having changes in the ABEM milestones that require some of this information to be looked at, that helps create an impetus to include this content. Like you said, one of the things that makes EM unique, and one of the reasons why we enjoy it, is because there's so many topics that have to be covered during the course of residency education. So anytime you're trying to advocate for additional material to be added to the lecture schedule, it can get very cumbersome. Some of the things where palliative care kind of naturally integrates into the curriculum that are important and have been recognized as ABEM, a lot of it relates to communication, because so much of palliative care does center around our communication skills. But these same communication skills that translate to talking about advanced directives and talking about care goals and dealing with strong emotions, that translates to other things like conflict resolution and some of the aspects of examination when it comes to oral boards and any kind of examination that requires those kinds of empathetic skills and those kinds of communication skills. This is a real good opportunity to highlight the role that palliative care can play, not only in teaching those skills for the sake of being able to have a goals of care conversation, to be able to navigate acute respiratory failure in the emergency room, but also to make sure that you have core communication skills that can be applied later. In addition, as pain management specialists and with all the requirements that are related to opiate use and misuse and opiate use disorder, that also puts us in a position to be able to add content that's valuable when we talk about things like buprenorphine and other modalities that people need to know about from a pain management standpoint, but they also need to understand those medications from an opiate misuse and opiate misuse or opiate use disorder treatment management approach.
And I think one of the things to emphasize here is in the change of format in the ABEM certifying exam, there's an increased emphasis on some of these communication skills around sharing difficult news, conflict resolution, and so this content will need to be taught more directly to residents in both the simulation format and in other formats, and so it is directly applicable to the ABIM exam at this point in the new edition. But what does this look like? What does it look like to actually integrate a palliative care curriculum into the residency? So there's lots of different ways to do this, and it's going to have to be individualized, but we're going to kind of share some of what we do just to get some discussion started. So it goes out saying, coordinate with your curriculum lead, and decide whether this is going to be something that maybe is done kind of in like a block format, or if you're going to teach it longitudinally, and lean into the bases of training. So perhaps, like Rita said, teach vital talk, those communication skills early, maybe like an intern boot camp, get that groundwork started. And then think about whether this is going to be dedicated palliative care time, or whether you're going to like integrate it into specific lectures that already exist. So for instance, if you already have a standard lecture on vent management, maybe you actually talk about compassionate extubation during that time. Maybe if like I'm at at the University of North Carolina, we have a sort of a block system. Each month is a different block topic. So aligning the topics that I'm talking about to what's going on in the block. So like in the resuscitation block, let's talk about serious illness communication and code status. And then talk about dyspnea management during pulmonology, talk about capacity and surrogate decision making during the psychiatry block. So things that relate to the blocks that are going on, but then other institutions, it might make sense to actually do something that is a little more asynchronous or mixed. And so to be more specific, so what I do is I have about 6 hours of content that we do over a year and a half, sort of mixed into the blocks. And we're a 3-year program, so that can cycle twice while the residents are going through training. And then we also do some simulation as well. Justin, or
Yep. The things that we've employed, we do a serious illness communication simulation that involves a end of life scenario where you have somebody and you're having to interpret advanced directives and medical decisions around that. And also we incorporate actually a pediatric SIDS case and having to manage like strong emotions when you're delivering bad news. The other things that we've tried, because it's so hard to work this into the curriculum, is, as Rita mentioned, we've developed some modules that cover things like advanced directives and covers pain management, end of life care management, symptoms, those types of things that all of our ED residents need to know. And also have had an intern boot camp lecture, just like a primer, because we've got people coming out of medical schools that have had good exposure to palliative care and some that they've never seen it used in the ED at all. So they need to have at least some kind of baseline understanding of how it might be incorporated.
So our boot camp for interns occurs just as Dan was saying, and we do a 4-hour course for our interns where they learn how to master tough conversations. And it doesn't have to do with the end of life, it just is serious illness communication. And that's where they're taught. Mostly they've got to learn how to master reframing the situation for the patient and the family, and they've got to have at the tip of their tongues the ability to give empathetic statements. That is very, very foreign to a lot of emergency physicians, so we really have to teach this. And then there's a new thing coming out. Obviously, use the Vital Talk resources. This is an organization been around for 25 years. All over the world taught how to have this serious illness communication. But the new thing that's coming out in November is something called EM Talk. It's specifically for emergency physicians who are going to be in the emergency department, just like we are, and have to have these conversations.
I think the theme that I hope you're hearing from all of us is that those who practice both palliative and emergency medicine realize that the skills of palliative medicine touch on almost all aspects. I end up using my palliative care skills in almost every shift I work in the emergency department. So think less of this as a cherry on top of your education and more as something you can weave throughout your entire curriculum to help drive home the lessons and improve the way that care is going to be delivered.
That reminds me what Dan just said was that, so if you're doing the heart month, end stage cardiac disease, you've got to give your residents information on what they can use if somebody comes into the ED and they really are end stage. And we treat that a little differently, especially if they don't want to have resuscitative measures. Same thing with end stage pulmonary disease. We just have to change our thinking a little bit.
Yeah. When you're talking about oncology, also talk about pain management. When you're talking about neurology and stroke, talk about prognostication. there's really room for this, and obviously it can't take over your whole curriculum, but you can find ways to have it be a part of each part of the curriculum.
And I think the last part is if you're going to build a curriculum, you should measure some outcomes. So we've had a couple folks here do that at their institutions, and Rita and Dan, do you want to share your experiences briefly?
Yeah, so multiple institutions have looked at this, and we see the same thing. When you expose residents or even faculty to these sorts of learning opportunities, they report that their comfort with engaging in these conversations increases. And you can go to the next slide. We also, in another setting, saw an increase by 1 standard deviation of people's self-reported comfort. And those of us who have engaged in these difficult conversations often report that the hardest part is that activation energy, getting yourself to walk into the room and start the conversation. But not just the touchy-feely stuff. When we test people on their ability to appropriately dose and prescribe opioids and then put them through these, we see improvements in their ability to answer correctly multiple choice questions. So multiple modalities show that these interventions improve people's ability to provide this care.
So we wanted to leave the end for a discussion. We'd love to hear from y'all in terms of, what are you a trainee? Are you a program director? Are you EM palliative care trained looking to create a curriculum? Do you have a curriculum? And just sort of engage if you've got experiences you would like to share with us that we could take away, or if you have questions, want to leave some time for that.
Who does this? Who actually trains their residents? Yeah? Can you just sort of tell us a little bit of how you do it?
Yeah, what's worked or maybe hasn't worked?
What's worked? Yeah, please.
Think it is many. So I'm a program director. We're at a new program in Arizona, and I felt that I did not get this when I was in residency in French and Penitentiary and other programs. And so we actually do something that I'm not sure if other places do, but we have a 2-week block for our interns where they actually do dedicated palliative care time, inpatient, and then they do a hospice experience. So I think we're still gathering data on how effective that is, if it's a good use considering the broad-based skill set that they need. But my goal and hope is that it provides them with more understanding, knowledge, skills to have these conversations and to understand what we do is more than just, acute care management.
Yeah, just comment briefly. I incorporated some of my other faculty incorporates some bedside clinical teaching. So, the first time you've never given delivering bad news or a death notification, you're going to watch. But the second time, you're going to do. You're going to be closely, monitor. The other one is around trajectories of death. So, that happens often. People are different trajectories. And I just have a 1-pager with all 4 trajectories. And then after the case is done, I just hand them the 1-pager and I say, which trajectory were they on? Maybe they've never heard of the trajectory, so it gives me 2 minutes to do some bedside teaching, and then that's it. So those are small little, how I incorporate it on the shift.
Yeah, I think that's great. We're all going to encounter opportunities to, unfortunately have to tell family members that their loved one has died, and having somebody watch you do it and then giving them a little bit of coaching, just-in-time coaching before they go in and do it is great. I also love the idea of hospice rotation. This is sort of off topic, but I feel strongly that for continued certification, anybody who practices medicine where you discharge people with care should have to go to a patient's home and see what it's like to do that care. So sending them to the hospice patients' homes to see what it's like for people to live, I think is incredibly rewarding.
I was just wondering if anybody has examples of working with other rotations, particularly ICU rotations that a lot of our residents do, where they might see some of these conversations and skills. Any models that are out there, great. Any thoughts and questions? Is that something I've been thinking about for our program? Where you're coordinating a lot of time here, so the luxury to bring in some of these dedicated rotations for everybody. But maybe another way to inject some of them.
Yeah, I'll try to speak to that a little bit. We don't have a model for our EM residents to do that, but since I do consults in the hospital as well, 50% of my time, definitely some outreach to try and have people involved when they can. But I do know a few of the residency programs at the hospital, I think neurology and internal medicine now, have started to try and create some partnerships with the palliative care consult team so that when we are doing some consultation. We can involve them more directly because when people are busy, it's really easy for them to be like, "Cool, child care team's going to come in and do their thing." But I like the idea so that perhaps maybe there's an opportunity when our residents are in because there's a lot of ICU time in similar settings to be a little more direct about how
We-
that happens.
Yeah, our palliative care faculty, I think that's the people to approach about teaching on outside of the emergency department. And our palliative care faculty will invite the resident who is in the ICU to please, would you like to get started on this meeting? But I'm going to be here to keep the meeting on the rails.
And one thing we did is we've expanded the intern boot camp. We are also giving that same instruction, but cut into pieces during the year for the entire rest of the residency because we know they'll be going through the ICU and we know they'll be having these discussions. So we've got to give them the tools to do that.
Yeah, similar lines. I actually got an idea from Dan because we have another palliative care person who's going to be joining our faculty. So we looked at our whole looked at our curriculum for the whole span, and we're taking those elements that were like, these are the things we know we need to cover, and these are the things we actually want to make sure we cover more than once because you're always going to have residents that are post night that miss your pain management talk, right? And then they're going to go through the rest of the residency like, I don't know how do you do that again? So and there was interest in that. So trying to make sure we reinforce those things that are going to come up a lot, like communication and like pain management. And then I would say probably some of the most rewarding family meetings I get to have because our ED residents are up in the ICU all the time is when it's that ED resident that's managing that patient and we get to do the conversation together and they share some and then I share some and then we debrief afterwards and have a chance to see what's different. And also definitely in the ED, I will take with a more junior resident, I will go do the conversation. And then when I have that big massive head bleed that we all know is not going to do well, I have the upper level resident go and say, okay, this is the things I would hit on. And I'm going to sit in that meeting and I'm going to do my best not to talk a whole lot. And then I want you to run it. And then we're going to talk about it afterwards and see how it went.
And I think that it helps to think of family meetings and goals of care's discussion as a procedure. You don't have somebody go do an intubation alone. You stand next to them as they do the intubation, and as long as it's going well, you let them continue to do it, and you intervene when you're not. And that sounds a lot like what Justin's describing there.
And we know we're out of time. The final piece I'll say, and I'm just going to touch on this because we don't want to tread down this, but with a potential move toward 4-year training program, there's actually more opportunity and discussion about how to integrate palliative care clinically. I mean, our residents can do it as an elective if they want to, but it's one every few years who choose to do that. But maybe some choose to do that a little more thoughtfully. All right, thanks for joining us.
Thank you.
You're welcome.